Dobré odpoledne ještě jednou, dámy a pánové. My teď ještě v rámci tohoto panelu u regulace legálních závislostí v úzovkách zůstaneme. Z několika důvodů, jak jsme viděli, tak minimálně Česká republika má velký problém s alkoholem, když Slovensko na tom taky není nejlépe, ale když jsme alespoň v rámci zemí OECD i Slovensko v té první třetině, alespoň s ohledem na nějakou průměrnou spotřebu. Stejně tak je tomu v konzumaci tabákových výrobků. A tak to znamená, že řešíme podobné problémy. V obou dvou státech se řeší, jakým způsobem regulovat spotřebu alkoholu vysokou, zejména v těch vysoce rizikových skupinách, stejně tak, jak regulovat vysokou konzumaci cigaret. A přece jenom v obou dvou zemích se i nyní, proto si myslím, že to je velmi důležité se tomu tématu věnovat. I teď je to extrémně důležité v této chvíli, kde nejenom na Slovensku, ale v Česku probíhá poměrně vášnivá debata o tom, jakým způsobem regulovat nejenom cigarety, ale ty nové nikotinové výrobky, jako jsou právě nikotinové sáčky. Česko, Slovensko bylo jedno z prvních zemí, které přišly v Evropské unii, které přišly s nějakou určitým regulatorním rámcem pro nikotinové sáčky. Teď řešíme, jakým způsobem regulovat elektronické cigarety i s ohledem na jisté přístupy, harm reduction a tak dále, takže těším se na debatu, která bude následovat teď v tomhletom následném panelu, kde budeme řešit, jak v podstatě najít ten správný balans mezi nějakou ochranou spotřebitele, ochranou veřejného zdraví a zároveň nějakým vhodným regulatorním rámcem, který bude minimalizovat ty nežádoucí dopady regulace, tak jak tomu v řadě regulatorních opatření je. Teď už mi dovolte pozvat na pódium dnešní speakery, so please let me welcome speakers for this panel. The first one will be Professor Dr. Bernhard Rupp, the head of the Health Policy Department Chamber. Dovolte mi prosím představit nebo pozvat na pódium i legendu české adiktologické scény doktora Csémyho. The next speaker will be Professor Ernest Groman from the Medical Faculty of the University of Vienna. And last but not least, Krzystof Landa, the president of the Ukrainian Society of Evidence-Based Healthcare, the founder of Watch Healthcare Foundation and former deputy minister on the health in Poland. So gentlemen, we will start with your presentations. All of you have 10 minutes, and I'll be measuring your time. And when you will have last 2 minutes, I will give you a signal, a little wink wink, so you know that you have just last 2 minutes, so we will be able to have all the presentations and also some space for the questions in the audience. So please, Professor Rupp, when I saw you for the first time in Brussels last time, you completely lost your voice. So I'm glad that you finished your tourney with your heavy metal band, because I believe you're a singer, and I'm glad that you got your voice back and you're able to present. So thank you, please.
Thanks for inviting me. Good afternoon. Yes, it's a little bit better than last year. Is there anyone who could help me to put my slides to the screen? Yeah, that's fine. Thank you so much. I'm a health economist by training and practice, and at the moment I serve as an influencer. This means I give advice to each and every decision maker that is interested in hearing what I have to say. In former years, I worked as a coordinator for in- and outpatient mental health services for Lower Austria. Lower Austria is an Austrian province with roughly 1.6 million inhabitants. At the moment, I also serve the Lower Austrian government. I'm a member of the board of the Lower Austrian hospitals and long-term care facilities. I have different approaches. I'm not a physician, as I mentioned before. I'm an economist and I'm an influencer. Therefore, each and everything, very relevant things, and I'm so glad that I had the opportunity to hear all this good information. Each and everything that is relevant has been said. My message is, how can we put the rubber on the road? Because it is about how can we make harm reduction a little bit more attractive even in Europe and in particular in Austria. That's what I'm trying to tell you. Well, this is my conflict of interest statements. There is no conflict of interest at all. Yes, that funny picture describes what I'm going to do. Of course, it would be the best not to smoke and not to drink alcohol. But what is the second best? What is the choice? What is the option? That is the whole story. The problem overview, it's more or less clear. We have different types of drugs. We have illicit drugs or illegal or legal drugs, but the border is not that clear, and some of you mentioned it in a quite funny way today in the morning, that we all drink coffee, and the WHO has also coffee on its list. It's a drug, but therefore we have to be a little bit more relaxed, and we should keep our eyes on what is feasible and what is more or less impossible to reach. Therefore, when we talk about legal drugs, what is legal, what is illegal, and we had also a discussion about cannabis, for example. Different European countries have the discussion to legalize or more or less legalize cannabis, and I also talked about caffeine. What we do see is some kind of religious wars when it comes to tobacco. It is more or less, even in the scientific community and for physicians, it's more or less accepted that we have some kind of harm reduction concerning illegal drugs and even alcohol. There are some physicians here in the room, I know that, even from Austria, and it is more or less a standard procedure to bring patients to drink less than more, for example. It's more or less accepted, but things are also questioned at the moment, and the colleague from Ireland or from Scotland, I'm not so sure, she told things are changing, and we have different politicians who are not that happy about having harm reduction any longer. Therefore, what has been clear for some years may be under stake at the moment. Well, we have, and it's part of the religious war, it's not my idea to label it that way. It is from Alfred Uhl. He's a colleague of mine. He's an expert from Austria, and he gave a presentation for the German Gesundheitsausschuss, for the German parliament. And what we do see is we have a restrictive approach, and he brought it together with some religious ideas that we find this restrictive approach more or less in Protestantic countries or Calvinistic countries. That's more or less true, but not in each and every case. When we regard the United States, we see some funny exemption of that. The restrictive approach, quit or die, you will know that, or the liberal approach. This means that we should empower the people to take care for themselves and, for example, to consume alcohol responsibly. High alcohol prices, and we had the discussion, what is the difference between the Scandinavian countries and the countries, Spain, Italy, or France. You all know the French paradoxon. They eat butter, they eat white bread, they drink red wine, and they are more healthier than the average. It wasn't for me years. Nobody talks any longer about the French paradoxon, but we had it some years. Well, high alcohol prices, this means, should we impose taxes? But what is the result of imposing high taxes on spirits, for example? Would the people drink less, or would they circumvent or use the other ways to get what they want? For example, in the Scandinavian countries, they take a boat, they go outside to the duty-free regions of the sea, and they come back. This means there are strategies to circumvent all the restrictions, and therefore we should be very careful in discussing that kind of stuff. Other restrictions in the availability, we all know this from the United States. I'm a graduate of the University of Toronto, and I had some semesters at the University of Atlanta, the Emory University, and I know what restrictions is. You all know this brown paper bags, and on Saturdays and Sunday you can't buy any liquors in some stores or whatever. And even restrictions on the marketing. But the question is, can we control even the marketing efforts made by some companies, for example, because we do not rely any longer on TV or movie theaters. We have social media. You can't control that. It's more or less useless to do that. Well, the liberal approach, we shouldn't apply restrictive measures in general. Sometimes it would be quite useful. Therefore, and I tell you now who is the murderer, it is a good blend, it is a good mixture of different strategies and approaches. We should have different methods and techniques focus on sobriety, and that worked. I'm also responsible. I'm head of the department at the Chamber of Labor of Austria, and occupational safety and health matters are also part of my daily work. And what we did see, even in the earth-moving industry, bricklayers and so on, in the 1970s and 80s, they drank beer. They worked they worked and they drank beer. What do we see now? They drink mineral water. Different other efforts to strengthen the persons and to help them to choose good choices. Well, the novel letter, and this is on the bottom line, what I'm trying to say is, we need a synthesis, we need a set of different keys, and we should discuss what is applicable and what is acceptable on the national level, because we have different cultures. Some like to drink red wine, some like to drink liquors, some like to consume very fat food, for example. What can we do? And you all know the letter, and we see different steps and different keys we should apply on that. Well, because I'm running out of time, I will skip all over that. This is all more or less clear for you, and I'll turn to the cigarette issue. And is it still quit or die, or what can we do? As I mentioned before, tobacco harm reduction is a thing. For example, in Austria, it's very, very hard to put harm reduction issues on the agenda of the political decision makers. They don't like it at the moment. They don't like it at all. And they are not interested in hearing arguments. They just refuse to put it on the agenda. That's the thing, which different opportunities are delivered by the industry. We have just told about it. And that's remarkable, because when talking about a Calvinistic country, the United States, the FDA has already acknowledged that there are some benefits in applying snus. The FDA is much more open-minded to that option than we see the situation in Austria. And please apologize, the next slide is very rude, but that's what we see in Europe at the moment. And that's not very helpful. We should have a dialogue, and it should be taken serious. It is not about fun, it is not about condemning different options. Yes, what about, let's stick to this news topic. It is not healthy, it is less harmful than smoking cigarettes, and we have some risks associated with snus concerning oral health problems, cancer risk, cardiovascular health problems, type 2 diabetes, and pregnancy-related risks. We all know that, but on the bottom line, and you know I'm an economist, on the bottom line this is it more harmful or is it less harmful, and what could be the benefit for the individual as well as for the community, for the state as a whole, and for the public budgets. And on the bottom line we have to say alternatives to the classic cigarette are considerable, useful, and we should give a boost, and we should support, and we should help researchers to do steps in the right direction so that we can generate evidence. Because most of the evidence we use nowadays is generated by organizations that are funded by the tobacco industry, and therefore there is a mark on it. Oh, you couldn't use the data because it's financed by the tobacco industry. Nobody would use that argument concerning legal drugs. Of course, drug companies finance different studies, and we shouldn't use that any longer. Of course, we should take into consideration there may be some conflict of interests, but we should take that into consideration, but we should take what we have and we should go a little bit further. Well, I'm finished.
Thank you, Professor. I still see the middle finger in front of my eyes, which I think very useful way how to describe what the government is thinking about the scientific evidence about the harm reduction strategies. But since we are short on time, pane doktore Csémy, pojďte prosím, pan doktor Csémy z Národního ústavu duševního zdraví a zároveň ředitel Harm Reduction Academy.
Všechny vás pěkně zdravím. Tady na začátek tady mám takový obrázek od mého oblíbeného kreslíře Renčína, který říká, tam tyho panáčkové tam sedějí, popíjí alkohol a říkají, tak na tu naši 4. příčku pití v alkoholu v Evropě. Děkuju mému předřečníkovi za to, že skoro všechno řekl, co jsem chtěl říct já. A to velmi zajímavým způsobem. Já, protože nejsem člověk, který je politicky zaměřený, i když sedím v různých jako komisích, které se zabývají nějakou alkoholovou nebo tabákovou politikou, ale hlavně se zabývám výzkumem, tím si vlastně vydělávám na své živobytí. Každý rok děláme národní výzkum užívání tabáku a alkoholu v České republice. Je to metodologicky velmi dobře zpracovaný výzkum a z toho výzkumu bych chtěl ukázat pár výsledků jenom proto, abych vám řekl, že dobrá data jsou vždycky výborným argumentem pro politiky, když s nimi o něčem jednáme a když je chceme k něčemu přesvědčit. Takže pokud jde o průměrnou spotřebu, bylo to už řečeno, v Česku od roku 2012 do roku 2023 v podstatě se ta spotřeba nemění. Ta takzvaná statistická spotřeba, vykazovaná statistickým úřadem českým 9,7, v roce 2012 9,9 a ty údaje, které jsou založeny na těch našich dotazových šetřeních, se taky moc nemění. Tady na tom grafu je vlastně vidět, že plus minus je ta spotřeba stejná. U žen se během doby od roku 2012 do 2023 zvyšuje a u mužů trošku snižuje, celkově je to v podstatě stejné. Na co chci upozornit, že v Česku je pití dost často spojeno s pitím velkých dávek alkoholu při jedné konzumní epizodě, binge drinking, čili týdně a častěji pije nadměrné dávky alkoholu při jednom posezení 23% mužské populace a 8,5% ženské populace. Kolega Kážmer už zmiňoval z této studie ta procenta těch lidí, kteří pijí škodlivě nebo rizikově. Dohromady je to zhruba 15% populace. My bychom vlastně v rámci prevence se vůbec nemuseli o 85% populace starat, protože ti pijí tím způsobem, že jejich pití jim neškodí a nemusíme je nějak ovlivňovat. Nicméně těch 15% činí zhruba 1,3 milionu lidí dospělých, takže není to opravdu úplně zanedbatelné číslo. Protože se chci zaměřit i na kuřáctví v té prezentaci, tak ta čísla, která jsem tady chtěl říct, už říkala kolegyně z Volska, čili v té naší studii vlastně vidíme, že dochází k poklesu kuřáctví jak obecně, tak tedy i kouření každodenní, jo, což je nyní na úrovni zhruba 16%. To, co narůstá a co jsme viděli, je kouření těch alternativních produktů, a to zejména u lidí ve věku 15 až 24 let. Tam to užívání elektronických cigaret na denní bázi je ve 12%. Čili o co jsme snížili kouření cigaret, tak o to se v té mladší části populace zvyšuje kouření nebo užívání alternativních nikotinových produktů. Teď, protože jsem měl mluvit jako k politikám, tak máme to, čemu říkáme národní strategie, bla, bla, bla. Jestli vás to bude zajímat, podívejte se na stránky Národního monitorovacího střediska. Ta národní strategie je vynikající, brilantně napsaná, doporučuji si to přečíst, velmi nekonkrétní. Potom k tomu máme akční plán, vždycky na 2 roky, a tam je prevence, léčba, regulovaný trh, efektivní výběr, prosazování principů, všechno tam je. Přečtěte si to, tak je to zajímavé, protože všechny nedostatky, které máme v té alkoholové nebo kuřácké politice, jsou tam vyjmenované, ale nic se nemění. Jako, jo. Na konci toho akčního plánu jsou konkrétní úkoly v různých oblastech. A tam je třeba konkrétní úkol pro ukázku. Rozvinout systém školské prevence a tak dále, jo. Termín rok 25, odpovědnost MŠMT, spolupráce, doporučení krajům, obcím, financování dle možností státního rozpočtu. Jako, jo. Čili ani koruna. A tak je to v mnoha oblastech, když se podíváte, jako tak málo kde se najde nějaký konkrétní číslo a i to konkrétní číslo, který tam je, třeba 100 milionů korun na něco, třeba na nějakou kampaň, tak kampaň zatím nikdy nebyla, no nevadí. Takže já si vždycky kladu otázku, teď takhle, ty české strategie byly vynikající pro vytvoření systému adiktologické péče o lidi, kteří užívají nelegální drogy. Ale to teda klobouk dolů, ale pokud jde o ty legální drogy, které působí 90% zdravotních, ekonomických a sociálních škod, tak tam tedy selháváme. A já si kladu 3 otázky ve vztahu k těm akčním plánům a strategiím. Jsou cíle konkrétně nebo příliš obecné? Lze dohledat vazbu na vědecky ověřené přístupy? Umožňuje alokovaná finanční podpora realizaci stanovených cílů? No, na to si odpověďte sami. Teď přejdu k tomu, co já si myslím, že by byly intervence, které by byly velmi nápomocné, abychom situaci změnili. A to je harm reduction. Já tady mám 2 definice, jednu vám přečtu, protože nemám čas na obě. A ta říká, snižování škod se týká politik, programů a postupů, jejich cílem je snížit škody spojené s užíváním psychoaktivních látek u lidí, kteří s jejich užíváním nemohou nebo nechtějí přestat. Charakteristickým je zaměření na prevenci škod, nikoli na prevenci samotného užívání. Harm reduction doplňuje přístupy, které se snaží předcházet nebo snižovat celkovou míru užívání návykových látek. Výborná definice. Jo. Používejte v práci s politiky, jo, ať se to naučí nazpaměť. No, takže mluvilo se tady o švédské zkušenosti v případě tabáku. Jo. Já tady přeskočím to, že jenom 7 nebo 5% lidí kouří ve Švédsku, ale 19% jich užívá snus. Samozřejmě výsledkem toho je, že úmrtnost a onemocnění mužů ve Švédsku, která jsou způsobena kouřením, je 72 na 100 000, zatímco v zemích EU 128 na 100 000. A pokud jde o nádorová onemocnění, tak je to ve Švédsku 14 na 100 000 a v EU zemích 36 na 100 000. Jo? Čili z toho vyplývá jediná věc. Bez ohledu na to, jestli jsou nějaká rizika spojená se snusem, se sáčky, s jakýmikoliv alternativními produkty, kromě zahřívaného tabáku, tak moje odpověď by byla ano. Doporučuji všem kuřákům, protože je to prevence kardiovaskulární, je to prevence nádorových onemocnění. Byť s nějakými riziky, Jo? Ale jako mnohem větší je riziko, když budete 30 let kouřit, jako že budete mít jako rakovinu plic a když přejdete na alternativy, tak to mít nebudete, tak se vám to nestane. Čili toto u kuřáků může být harm reduction přístup příhodný pro méně motivované kuřáky, nebo ty kuřáky, kteří selhávají. Jako Mark Twain říkal, přestat kouřit je snadné, zkoušel jsem to 1000krát. No. Ale potom ty harm reduction přístupy jsou taky významné pro lidi s vážnou duševní nemocí, jo? Protože tam je velká prevalence kuřáctví a lidé s vážnou duševní nemocí, schizofrenie a tak dále, těžké deprese často předčasně umírají kvůli kuřáctví a ne kvůli té své nemoci. Tady je nějaký iniciativa WHO, kterou já přeskočím, protože skoro nic z toho neplníme, kromě dostupnosti alkoholu 18, ale dostala do ruky velmi zajímavá studie, kterou vydalo OECD. Dostalo se mi to do ruky, protože oni si ode mě vyžádali data. A potom vydali takovou knížku, kde zpracovali, jaké intervence v oblasti alkoholu jsou nejvýhodnější a jak jsou ekonomicky výhodné. A srovnali Kanadu, Německo, Českou republiku. Já jenom budu mluvit o České republice. Tady se ukazuje, že z těch intervencí nejvýhodnější a nejúčinnější jsou krátké intervence, které provádí v podstatě praktický lékař, který vás velmi dobře zná, nebo velmi dobře zná svoje pacienty. Pak je tady metoda, která je účinná též velmi, a to je zvyšování daní. Pak je to omezení pití při řízení a omezení otevíracích hodin pro prodej alkoholu. Z těch ostatních jako nejméně účinné se ukazují školní programy prevence. Jo? Že oni v podstatě dávají informace, které ty děti někdy ani nevnímají a v podstatě je to věc, která nepřináší příliš velký efekt. A teď, když se tyhle informace nebo tyhle intervence posoudí z hlediska nákladů, tak co vidíme tady a co je hrozně zajímavé? Důležitá věc je léčba samozřejmě, ale léčba je nesmírně nákladná. Je oproti tomu, co se ušetří z hlediska nákladů zdravotní péče, tak je ta léčba závislostí nesmírně nákladná. Nákladná je i ta krátká intervence, protože vyžaduje školení praktických lékařů a tak dále, nějaký čas, který to musí věnovat, který by měl být zaplacen a tak dále. Jo? Nicméně ty náklady jsou nižší než úspora ve zdravotní péči. Jo? Ten tax increase ten nemá prakticky žádné náklady, tak pochopitelně tam nějaká úspora je. Ty ostatní nejsou tak významné. Významný se zdá být jako minimum price. Minimum price to je jednotková cena na dávku alkoholu, s tím mají ve Skotsku dobré zkušenosti, si myslím, už, nebo nějaké zkušenosti. My zatím s tím zkušenosti nemáme. Čili jsou práce, které na základě existujících dat a postupem mikrosimulace ukazují, které modality intervencí bychom mohli s výhodou použít, kde můžeme ušetřit nějaké náklady a kde to přinese největší efekt. Jo? Takže my ty informace máme, akorát je musíme konkrétně vtělit do nějakých programů a přesvědčit politiky, že to je možné. Já jsem před lety dělal studii na krátkou intervenci u praktických lékařů. Toto je hlavní výsledek. My jsme dělali tu studii v 10 ordinacích praktických lékařů a ta týdenní spotřeba v gramech alkoholu po 3 měsících klesla v jedné skupině z 265 na 175, čili ukazuje se, ano, jde to, ale je nutný se tomu věnovat, je nutný vyškolit ty lékaře, přesvědčit je, že to má smysl a pak vidíme, že to jde. Tady nešlo o to, aby ty lidi přestali kouřit, protože když jim ten doktor řekne, vy musíte přestat pít alkohol, tak oni nepřestanou pít alkohol. Jo. A když jim řekne, podívejte se, já mám starost o vaše zdraví a vidím, že vy máte ty a ty zdravotní potíže a myslím si na základě toho screeningu, že mohou souviset s vaším pitím alkoholu, doporučuji vám nějakým způsobem a já vám pomůžu, jakým způsobem snížit tu spotřebu. Tak to ty lidi přijmou. Nepřijme to 100% těch lidí, ale když to přijme 10% těch lidí, tak už to má význam z hlediska public health. Jako kort v zemi, jako je Česká republika, kde ta spotřeba alkoholu tak vysoká. A na závěr jsem chtěl ještě poslední obrázek, když se trváte, prosím vás. Četl jsem takovou studii, a toto je k zamyšlení místo nějakého souhrnu. Nedávno se mi dostala ta studie do ruky, byla publikována v roce 2003. Ta studie se zabývala jednak tou takzvanou křivkou, která říká, že vlastně pokud jde o mortalitu, tak u těch lidí, kteří konzumují 1 nebo 2 drinky za den, je jistý malý protektivní efekt a potom od těch 2 drinků denně, a byla to americká studie na 980 000 lidech a 1 drink v Americe má 14 gramů standardní, takže 2 drinky jsou 28 gramů, 1 pivo má zhruba 16 gramů alkoholu, takže od těch 2 piv zhruba více, pak se zvyšuje teda ten rizikový efekt toho nadměrného pití. Jako jo. Nicméně nezvyšuje se tak dramaticky, jako se zvyšuje protektivní efekt 30-minutové chůze za den. Jako jo. Takže to je to, co chci říct taky, že máme různé přístupy, jakými my můžeme motivovat lidi k vyšší kvalitě života, k lepšímu žití a většímu zdraví. A jsou to naše preventivní intervence, naše legislativní zásahy, naše regulace cenou, ale je to taky prostě nějaká zdravotní výchova, zdravý chování jako pohyb a tak dále. Jako jo. Tak děkuji, že jste mě vyslechli.
Děkuji panu doktorovi Csémym. Jsem rád, že jste zmínil akční plány, protože Česká republika je světovým přeborníkem v psaní akčních plánů, který se pak zpravidla takhle vezmou, strčíš je do šuplíku a nechají se tam napak, takhle potom. Takže je dobře, že jste zmínil, máme jich spoustu, tak třeba se nám nějaký podaří splnit. So the next speaker will be Professor Groman from the Medical University of Vienna, who is also a huge fan of sugar cakes.
Thank you very much. No, I just promote them. So if you want to buy one. No, I have no contract with the Sacher Cake Company. Yeah, so thanks a lot for the invitation. I'm happy to be here today. I just want to mention I was born in Vienna. My grandmother, one of my grandmothers is from Czechia, and the father of my grandfather was from Slovakia. And they both had some funny discussions, especially when they were angry about each other. Yeah, you can imagine. Yeah, okay. We can go in more detail. I call it nicotine policy. You know, policy is what you can do, what you are able to do. Or as we in Vienna say, it's die Kunst des Möglichen. I'm also happy that my former teacher, Professor Gabriele Fischer, is here, so I hope I will get then enough. He's already looking at the watch, yeah, so I got 5 minutes for this talk, then I said I need 1 hour, then they said 7 minutes, so now we are at 10 minutes, I guess. Okay, 10 minutes, you have to negotiate, yeah, it's policy. Yeah. This is the main basic slide. People, smokers die from tar, they do not die from nicotine. And we have to find a way to give them the opportunity to consume nicotine in the least harmful form. We did this publications, or our group did it many decades ago, and very little happened in between. So it was lung cancer risk in women in relation to tar yields. We even were able to calculate tar risks for different brands of cigarettes. You can imagine the companies were not too happy with us. If you say this brand has this cancer risk and the other one another one, you are not too happy about it. And with nicotine, we have the issue of dependence. People can get dependent on nicotine with all the difficulties to quit or reduce consumption. You see here the two young people. You see they're happily trying quitting and have some interpersonal debates also. No, for the man in the auditorium, if your wife is looking that way, I can say something is going wrong. Yeah, you have to take care about it. We also published about nicotine receptors in Vienna when in the Wiener Klinische Wochenschrift, when it was smoking was seen as a habit, something you are doing, a bad habit you can quit easily. Then we published as a receptor there's some neurological things going on. And as I have to take care for the 10 minutes, I go over this very quickly. So you have an upregulation of receptors if someone is a smoker, and then under withdrawal you have, no, we go desensitize. We go over this quickly if the system worked. Yeah, here. We have this nicotine substitution, classical medications, patch gum, inhaler, lozenge, and mouth spray, which are now today generally accepted by the medical field, but also by the population. I told you in the beginning it was also an issue, yeah, to put them on the market, because people say, yes, people will get dependent on the nicotine gum. Of course, this can happen, but he reduces his star. And then we have this category of new products which are now under debate, and the regulation is going on or is not going on, depending on the political situation. So we have the three categories. You heard about it. We have the nicotine pouches, the e-cigarettes, and the tobacco heaters. These are two heaters of two different companies to keep it neutral, because it's difficult here, yeah, because usually you can recognize who is the manufacturer, so I put two on the slide. Yeah, what we want is a reasonable regulation. You know, the lady here is blind, whatever this means. You are the lawyer, it's justice, isn't it, if you are blind, but maybe sometimes you do not see everything. Yeah, we have consumer preference. You cannot go against Sacher cakes, at least not for long. And Sacher cake, before doing a presentation like this, it might be also a good thing if you increase your sugar levels. Of course, if you eat Sacher cakes all the day, it might be bad. Then we have the issue of flavors. The president of the German dentist told me, Ernest, I would never thought 2 years before I was a cigarette smoker, I'm now using e-cigarettes with watermelon taste. I would have never believed this before. And so we have to find products which are accepted by the smokers. And flavors is not just fruit flavors, where some say they attract young people, which might be correct, of course. But on the other side, you get away from the tobacco taste, and it might be also some kind of relapse prevention. If you say, I like watermelon, if you then try a cigarette, you do not find many watermelons in a traditional cigarette. Then we have to find the right nicotine content, yeah? Working with smokers half of my life, I always had the complaints with traditional nicotine replacement products that smokers told me they do not work, which meant they are too weak. And the other argument was when they were complaining they do not taste, then we are again at the topic flavors. So we need products which are strong enough and which with a flavor or taste which is accepted by the people. And then you would ask, what is best? What is the least risk? And I say, we are happy, and of course you are people from the addiction field, so you know what I'm talking about. We are happy if we found some, so to say, replacement which is accepted by the patient, by the smoker. And it's the first step to get them free from the cigarettes. Yeah, And now what is under debate, even the public communication has to remain open. We have so lot misinformation in the public that, for example, I meet, there's a lady who always delivers vegetables to my wife. I do not know why, but this other story. And she told me, Ernest, you are looking at this, the risk is the same for everything of these products and cigarettes. I said, no, it is not. But you see, we have to inform them. There has to stay at least some channel open to communicate that the new products have reduced risk. And he says me 2 minutes and I might be able to do it. Do I get the prize afterwards or something? Because the other ones were longer, you know. Yeah, you say negotiation again. Yeah, and this is the warnings. It's, yeah, of course, it makes the pack of cigarettes, the brand, unattractive, yeah. But if you have someone who has smoked 40 years and was eventually a happy smoker for most time of his life, it will not really help him. And what I also say, with the new products, warnings should reflect the risk of the product. And we should avoid, of course, I understand it, if I would be a bureaucrat, the most easiest thing is just doing copy-paste. You know, you take the old law and you use it for the new product, you have finished it in 5 minutes. But we should avoid this. And this, I want also to mention, it's not just alternative products, it's also other policies. We also want a reasonable price policy. For example, we know if you increase price for cigarette and you might decrease it for replacement products, it might also help. We have a price elasticity of products, a cross elasticity between products, but I do not want to bore you too long. You find this publication is in the internet, it's freely available, it's Felsinger and Groman, and we did some strange calculation and we found out what helps and what helps not. And it's, yeah, you can, yeah, we have 1,284 views, so some people at least looking at it. And of course, we have the topic of use prevention. 1 minute, okay? Just to be politically correct. Of course, it's not the best, eventually not consume psychoactive substances at all, but I'm not totally sure here, because if you really do not feel well, it might help in a short time. We have high price of products, we have realistic but reinforced age limits. I'm waiting for the next politician who comes, well, we forbid smoking till the age of 25. You know, you can say it, but then at the moment we have the age limit of 18 in Vienna, and there's a school below my window, and if I look down I see the 16-year-old smoking. So if without reinforcement we can simply say we do something. The reduction of easy availability, advertisement rules, and then what's the most important thing is the example of teachers, adults and parents. Usually if I say this at the school project, I am not invited again, because I said we make the room of the teachers smoke-free first. Then they didn't, but they did, of course they want to forbid it for the children. And the promotion of healthy lifestyle, yeah, of course we do not want this. We want the monitoring of the market to see what happens if some product increases, who is consuming what and when, then that you can take counter measures. And yeah, we want young people like this, of course. So thank you very much. How much did I? Perfect. Thank you.
So thank you, Professor. I believe you deserve a sugar cake, definitely. So the last but not least, we are short on time. So I would like to invite the last speaker, which is Krzystof Landa, the president of the Ukrainian Society of Evidence-Based Healthcare and the founder of the Watch Healthcare Foundation.
Thank you very much. Good afternoon. Thank you for the invitation. I'll try to be quick because there is no much time left, although I'd like to pose some key messages to you. maybe my Ukrainian position is not of the greatest importance here. I used to be Deputy Minister of Health in Poland. I spent last year living in Kiev, but right now I'm again in Warsaw, dealing also with health technology assessment, mostly promotion of evidence-based medicine and evidence-based healthcare. And this is the topic of my presentation, as we performed a systematic review on most important and widespread methods of nicotine uptake. So on regular cigarettes, on heated products, on e-cigarettes and nicotine pouches. I'd like to refer to the proposition that we shouldn't take into account studies which were sponsored or performed by industry, as well for nicotine products, as well as for medicines. I strongly disagree with that. You know, if we stopped pharmaceutical companies from doing and financing studies on medicines, we wouldn't have progress in medicines. We have GCP, good clinical practice principles, and that clearly states what is the role of the sponsor. And the same, I believe, that if you perform registries, you need to cope with good registry practice principles. If you perform, some laboratory tests, if this laboratory is certified, and then you may compare what results are being received by so-called independent laboratories and dependent on industry laboratories. I think that in modern studies there is not much discrepancy with that respect. So I disagree. I think that if the role of sponsors is clearly stated, study is valid, I will take it into account. Nevertheless, look at the Tobacco Productive Directive of the European Union that really points out to the European Union Treaty. And the European Treaty has a very clear provision that all policies, including health policies, should be based on evidence, should be based on valid trials. And I believe that final result, when we get to the laws implemented to European Union member states, I hope that they are going to be well rooted in valid evidence. What we see, at least in Poland, is there are some orthodox people. They are really against nicotine uptake, and their opinions are really not based on evidence. I would rather say that they are driven by emotions and some orthodox approach, I don't know, rooted on something to fight against. Nevertheless, I believe that, and probably you know, that systematic review is on the top of WHO pyramid of evidence. And now, you should also know that currently applied or endorsed tobacco directive of the European Union is outdated. It is based on the trials from 2009, 2014, and these are really mostly observational studies. Even some, let's say, technologies or some interventions which deliver nicotine to the users, they were not even on the market yet. So it is certainly obsolete, and I think that we should negotiate based on evidence its update. And this is actually what is going to happen. Currently, from the 1st January 2025, Poland, Denmark, and Cyprus are going to lead presidency in the European Union. And Danish Minister of Health already has announced that they are going to open up discussions on the tobacco directive. I hope they are going to be based on evidence. And here is my company, I'm the partner there. We perform systematic review of 3 streams, or in 3 dimensions. So Chemical, we investigated all clinical evidence available at the moment on chemicals, so toxins, content in the smoke or sachets, and then biomarkers, and then clinical with respect to patient-oriented outcomes. And we have this evidence collected. If you contact me, I have my email address at the end. I will send you that in the English version. All these streams, they aim the same direction, and they prove that there is a continuum of risk. So the worst you can do is to smoke regular cigarettes. Much better it is to have combustible, so heated products, as temperature is lower. But then there is a big gap, and then you have electronic cigarettes, you have non-tobacco pouches, nicotine pouches. In Poland, at least, our politicians don't recognize difference between snus and nicotine pouches. This is a problem because they don't know that snus is being used in Europe only in Sweden, while you have in other countries you have available nicotine pouches with pharmacopoeial clean nicotine. So they don't contain any substances associated with tobacco. Then also in Poland we have a very big problem because our politicians, they actually aim at protection, mostly youngsters, from initiation of nicotine use, while they forget about smokers and what smoking causes, what are the effects on our health, national health fund, on various things around smoking cigarettes, including major risk of highest risk diseases. And I like the harm reduction. Harm reduction, that was definition given here today. It is everything what improves situation of the smoker. So let's not forget about the second goal. And certainly, if you remember the second presentation today, there was a chart like that where we should all look for optimal regulation. If there is no regulation, it is very bad. But also over-regulating the market, it is very, very bad. And here we have consequences, terrible consequences from over-regulating market in Australia. If you want, again, contact me. I will give you references on that. Wishing politicians evidence-based policy making and finding the optimum of regulation. Thank you for your attention.
Thank you very much. Thank you all the speakers for great presentations. So right now, do we have any questions from the audience? Yes, please.
Zdravíčko, ďakujem vám všetkým pekne za prezentácie. Chcem sa vás spýtať, že akú rolu v tejto problematike zohráva kultúra, lebo vidíme, že vlastne Československo je kultúrne veľmi zaťažené na alkohol, zapíjame úspech taktiež ako neúspech a je celkom vo veľkom tolerované, že máme prestávky na cigarety, takže či táto kultúrna problematika zohráva v tomto celom veľkú úlohu a prípadne čo sa s tým dá robiť v budúcnosti alebo kľudne aj v nejakej krátkej budúcnosti. Ďakujem pekne.
Does anyone want to take a chance to answer the question? Thank you.
Well, I guess when we compare to the Americans, and I have to stress, I'm not an alcohol expert, I'm a tobacco expert. You have, for example, the Catholic background, you have the Protestant, Calvinistic background, so maybe there it's more black and white, and here it's more gray, so we get the impression if you smoke a little bit, it might be okay. If you smoke 60 cigarettes per day, it's not okay nowadays. It has changed. And if you go to drink alcohol and consume it in your cellar, then it's also a different mindset than compared you get drunken in the public, or if you hide it in a plastic bag. You know, there are some laws in some countries. So I would say the background plays a role, but it's also the social background. So if we go back to smoking, because this was more on smoking, when I was young, it was fashionable to smoke everywhere, and I did a project at the OMV, which is the oil company, the Austrian, and there was this huge discussion room with this huge desk, and you had an ashtray at every second seat. And it was a blue room, and it was the director was also smoking. And some years after I met him, and he was quite unhappy because he said, I want to quit smoking because it's just the how do you say it politically correct? You're the social democrat, I guess. The social, not advantaged people who smoke. I do not want to belong to them. So it got unfashionable. And I think this plays also a role. With alcohol, at least in Austria, I do not see this differentiation. People drink if I'm at the blue-collar workers, and also when I come, apologize me, to the university professor, so it goes through the society. Yeah, what would you say? I think it plays a role. No?
I'm an economist and not a psychiatrist or a psychologist. We have cultural aspects, and you remember I mentioned during my presentation that we have the French paradoxon. We have different tastes, we have different cultures, what we drink, when we drink, and what we do eat. To change the culture is not that easy, but it could work. Ernest, do you remember when we were young students, maybe you commuted, I went on the train every day from St. Pölten to Vienna, to the university, and then back. At the time, on the train we had smoking compartments and non-smoking compartments. It was. And usually nobody sat in the smoking compartments because it was very stinky in there. The smokers went to the non-smokers compartments, and only if they want to have a cigarette, they went over there. And I was a non-smoker at the time. I always sat in the smoking compartments because there was always an empty seat for me. It's impossible, and even you might remember flying an airplane, riding on an airplane. At the time, you could smoke. You could smoke in public transport systems, in buses, and so on. The things changed in Austria, and you also remember I talked about the attitudes of workers, of blue-collar workers in the earth-moving industry, bricklayers, and so on. They did drink beer, nothing else during the working hours. Now we have a tendency, we have regulation, we have the Arbeitnehmerschutzgesetz, it's occupational safety and health regulation. They are not allowed to do that, and they obey. And they do it not so much because they are under control, because they are convinced that it's more or less useful to drink soda or whatever. Except alcohol, everything you would find on the workplaces now. Things changed, even the culture changed, but some things would never change. Having a celebration like a birthday party or whatever, you have to raise a glass, and it's a little bit strange if you refuse to take a glass and to say, well, happy, whatever. But this is my personal observation. This is not based on evidence or whatever. But I wanted to turn to you because I guess it is a misunderstanding. I mean the same like you. It is funny that we have no problems, that drug studies are financed and sponsored by the drug industry, but we have problems if the same happens with the tobacco industry. I guess we should take into consideration that there is a sponsorship and there might be conflict of interest, but we do mean the same. Sorry, I was unclear in my presentation. I'm with you. Sorry, I can contribute nothing else to the cultural issue.
Maybe I can add a little bit. I now remember I was working in the wine quarter in the hospital, and we often had patients there who had a really alcohol issue. They were alcohol dependent, and of course then they didn't get alcohol in the hospital, and they got all this, we say in Zugserschein, this they got their issues, and then their relatives came and asked us, what did you give him that he behaves that way? And when you told them it's not what we have given, it's that what we have not given to him, then they were angry with you. So I think the first important thing is that there's some awareness in the population that there might be an issue, and that we are able to talk about openly, yeah, not putting people or hiding. Then we had the visit of the local Bürgermeister. He visited us, and so we distributed these alcohol patients that he does not realize it so much. We distribute him through the whole hospital to different rooms. The action was, no one was sleeping this night in the hospital, because in the night they got their issues. But usually, of course, for example, if you the political administrator of a region who is depending on alcohol production, then you try to avoid the topic. And when I was invited there, I was always happy that I was invited to talk about tobacco, because they liked me, but my colleagues from Karlsburg who had to speak about alcohol, they were not very well perceived, so to say.
Já teda jsem taky ekonom, ale možná k tomu jenom dodám k těm kulturním rozdílům. Myslím si, že v tom hrajou obrovskou roli. Vidím vás, že v tom hrajou obrovskou roli, protože i když třeba skandinávské země, které jsou nám dávané za příklad a jsou daleko lepší v dodržování pravidel, tak i tam má přísná regulace spotřeby alkoholu svoje nezamýšlené dopady, které to už koneckonců byly i zmíněné, což byl jako vznik úplně nového odvětví těch alkohol tours, to znamená, že jsou tam jako několika patrové lodě, které vás naberou v přístavu, odvezou vás do mezinárodních vod, tam se všichni opijou, nakoupí si alkohol domů, ta loď se vrátí zpátky do přístavu, nabere novou posádku a takhle to tam točí prostě celý víkend. Takže to znamená, že ty lidé si vždycky najdou nějakou cestu i přes přísná regulatorní opatření. Myslím na vás. I see you have a question, but I have just one more question for Dr. Csémy, because we are talking a lot about tobacco and the harm reduction in the area of tobacco. So my question is whether we have some tools from harm reduction perspective that we can use in the regulation of the alcohol consumption. Máme nějaké harm reduction přístupy, které můžeme použít v regulaci alkoholu?
Pokud jsem zmiňoval ty krátké intervence v prostředí nebo prostřednictvím lékaře prvního kontaktu, to znamená praktického lékaře, tak to je forma harm reduction, pochopitelně, jako jo, protože ta se nezaměřuje nebo nenutí toho člověka vlastně k tomu, aby abstinoval, ale říká, jakým způsobem a proč by měl být motivován k tomu, aby změnil svůj vztah k alkoholu a změnil svoje chování. Jako jo. V případě, že ten praktik má ten screeningový score velmi vysoký, tak on ví, že už prostě tady není cesta a prostor pro krátkou intervenci nebo pro harm reduction, ale tam už prostě na základě toho i svoji zkušenosti doporučuje prostě odeslat k nějakému odbornému lékaři. Jako. Kromě toho jsou známy pokusy o podávání regulovaných dávek alkoholu například některým sociálním skupinám, jako jsou třeba bezdomovci a tak dále, což považuji za jeden z možných přístupů v oblasti harm reduction ve vztahu k alkoholu. Jo, takže asi tohle. Ale myslím si, že obecně na populační úrovni ta krátká intervence u praktického lékaře je to, co bychom měli nejvíc kultivovat.
Já prosím poslední dotaz z obecenstva, potom si dáme obědovou pauzu, so please, the last question from the audience is yours.
Thank you. So the culture question I think is really interesting, but for me culture is not homogeneous, and when we're talking about drinking, we're talking about men drinking. So all the data that has been shown, and we know this, it is much more men who binge drink and drink excessively and are responsible for the high rates of consumption. So I think when we talk about harm reduction, we have to think about a sex and gender approach. But the other issue, and I think with alcohol, and I've mentioned it this morning, is about the power of the alcohol industry in the countries. And how much you think that's related, because Czech Republic, brewing is one of the biggest industries in Ireland and Scotland, and they have huge power. So you mentioned the MUP policy, which the alcohol industry, so with minimum unit pricing, they fought for 5 years in the legal courts to stop that. So I think this is another issue, the political economy of the alcohol industry in the different countries also. Thank you.
Thank you for the very valid comment. Děkuji všem za pozornost, omlouvám se za přetažení a zkrácení vaší obědové pauzy, která začíná právě teď. Přeju všem dobrou chuť a uvidíme se zpátky v 14:30. Děkuji.